Hello, ladies and gentlemen. Time flies. We have come to the near end of this 6 hours AICT-AsiaPCR symposium. But I can assure you that this is maybe the last, but not the least in terms of symposiums. And this is sponsored by Terumo Company. And we're going to be focusing today on deep dive into transradial intervention PCR from big data to clinical practice. Next slide. Our learning objectives today is to understand the value of big data in clinical practice. And we're going to learn the strategies of primary PCI in STEMI patients with cardiogenic shock via a transradial route. And we also want to learn the management of complications associated with transradial intervention. And with me as co-faculties will be Dr. Takashi Kajiya from Japan. And we have Dr. Jack Tan from Singapore. And we have Dr. Fazila Malik from Bangladesh. So immediately after this introductions, I'm going to introduce Dr. Fazila Malik, who is going to give the opening lectures on the power of big data from 37,000 patients. Dr. Fazila Malik.
Friends and colleagues, it's really great to be here with you today. And we all understand that much research and studying has been undertaken for the Ultimaster stent. There have been numerous randomized control trials which have established the safety and efficacy of this stent. And many registries have also been done to see and evaluate different subsets of patients. And indeed, one such very large registry is the Ultimaster registry. In fact, it is the world's largest registry. It dealt with 37,198 patients. These patients were suffering from coronary artery disease and were implanted with the Ultimaster stent. And these patients were enrolled from 378 hospitals from 50 countries spanning 4 continents. So you can imagine the magnitude of the data as well as the diversity of the patient population. And these patients were followed up for 1 year, and the 1-year follow-up rate was excellent. It was 95%. And this was a true all-comers global study with a wide geographic range. And the great thing was that there was quality data adjudication of any adverse events. So this Ultimaster study is unique because it's a very, very large study with a huge number of patients. And it also gave us an insight into the diversity of patient population in different geographic regions of the world, and also gave us insight into how interventional cardiologists from different parts of the world treat their patients on a day-to-day basis. And what did we find? We found that among the risk factors, hypertension was the most prevalent, with a prevalence of 68% globally. However, in South America and Mexico, the prevalence was 78%. Dyslipidemia prevalence was 60%, and in case of the European population, it was 62%. For diabetes, however, in the European population, it was only 25%, and this was almost double in the African and Middle Eastern population, the prevalence being 47%. The Asian population was the least obese, prevalence being only 17%. If you look at the age of the population, in the European population, the average age was 66 years. However, for the African and Middle Eastern population, the age was 60 years, 6 years younger. And this was closely followed by the Asian patients whose average age was 61 years. Regarding the clinical presentation of these patients, 55% of the patients came with an acute coronary syndrome. So these patients were pretty sick, and 35% had non-STEMI globally, and 20% came with ST segment elevation, myocardial infarction. If you look at the type of lesion, Globally, the prevalence of left main disease was 3.4%. Bifurcation lesion was almost 13%. And in case of CTO, it was 5.5%. However, in Asia, it was 6.9% CTOs. If you look at multivessel disease, in case of Africa and the Middle East, multivessel disease was around 54.8%. However, globally, the prevalence was around 46%. Regarding the procedure, what was done, direct stenting of the lesion was performed in 41% of the cases, and this was more prevalent in Africa and the Middle East, 48%. Post dilatation of the lesion was done globally at around 40% of the patients. This was highest in Asia. Around half of the patients, 48.3% patients, had post-dilatation done to their lesion. A very important message is that there has been a worldwide implementation of the radial access. Radial access, globally, 82% of the interventional cardiologists chose the radial route to do their PCI. There was some difference in the implementation of the radial route according to region. In Europe, almost 90% of the procedures are being done through the radial route. In the case of Africa and the Middle East, it's around 50 to 57%. IVUS in the real world, it seems, is not as commonly used. In fact, it's very rarely used, the exception being Japan, where it is done in almost 90% of all their procedures. If we look at the use of DAPT at 1 year, we find that for chronic stable angina patients, post-PCI, even 65% of the patients were on DAPT at 1 year. And for non-STEMI and STEMI patients, around a third of these patients were not on DAPT at 1 year. And if we look at patient outcome, it seems that Ultimaster stent is an extremely safe and effective stent with a target lesion failure of less than 5% and an incidence of stent thrombosis of less than 1%. And what were the major risk factors for target lesion failure? Well, it seems diabetes, renal impairment, left main disease, and graft treatment are the major predictors. And these major predictors were found by multivariate logistic regression model. So what emerged from the eUltimaster registry, which is the world's largest global registry, will be found that the independent clinical predictors for target lesion failure are age, diabetes, renal impairment, previous revascularization, and acute coronary syndrome. We found that the Ultimaster drug-eluting stent shows an excellent performance at 1 year with a target lesion failure of less than 5% and a stent thrombosis rate of less than 1%. We found that the radial access is widely used globally. More than 80% of the patients were done PCI through the radial route. Intravascular imaging is really used with the exception of Japan. DAPT is used in case of acute coronary syndrome in 70% of the patients at 1 year. This largest registry, the Ultimaster, has given us indeed unique insights into what is globally practiced by our interventional cardiologists when they treat their patients. And this large data has also given a high level of granularity, which will allow deep analysis and will contribute to our greater understanding of different subgroups of patients in different parts of the world. With that, I would like to say thank you.
Thank you very much, Dr. Fazila Malik. That was a wonderful coverage of the registry data of eUltimaster. We always talk about randomized controlled trial being the gold standard for any sort of comparative efficacy study, and yet observational registry do have its own advantages as well. I think foremost of which is that it is an unselected population of patients that's being enrolled, and so it's generally generalizable in terms of its findings to a population. And also we know that eUltimaster registry, for example, like most of the registries, taken huge number. And so you can actually look for infrequent occurrences of event and also study hard clinical endpoints as well. And so it's quick enrollment and it's inexpensive. So I'd like to ask Dr. Jack Tan for a start, what is the major take of your eAltiMaster registry from what was presented?
Thanks, Huay-Cheem and Fazila, for a great presentation. Two observations. One is that this is truly big data and very real world. What really impressed me was the safety results. In fact, the fact of two observations. One is that the rates of post-dilatation is still pretty low in this real world practice, which I found slightly disappointing. But in spite of that, in spite of the fact that DAPT duration is usually less than a year in a lot of countries, the safety is really quite impressive. Second thoughts is that although the median reported radial access was in excess of 82% median, you could see that in centers which adopt a radial first access, it's almost close to 100%. So it seems to concur with our experience that centers who go for a radial first approach will then learn to use it properly and then be very enamored with this approach and will not go back to a femoral first approach. It's only those centers that are predominantly still on a femoral approach that needs to come to a radial approach. Thanks, Huay-Cheem.
Thank you. Fazila, do you have any comment on what Jack said? Takashi, so how often is transradial intervention being practiced in Japan? Because I would imagine it to be as high as Europe, and yet we are not seeing it in Japan close to 90% or 100%. So what are the barriers in terms of the use of a transradial even in Japan or in some part of Asia?
Thank you, Prof. Tan. So I said roughly 90% cases are done by TRI, but the exception is only for the hemodialysis case. So hemodialysis case, of course, we have to keep the radial artery, so we use a transfemoral approach. But other cases, we go radial first. And maybe in some complex case, very difficult CTO case, some people likes to do a transfemoral approach. But I said around 90% we can complete PCI by a transradial approach.
Yes, I think this is probably the practice also in Singapore. I get it. The majority will still be transradial, apart from some very complex PCI. I know from the eAltiMaster registry, Fazila, can you hear me? But I can't hear you very well. That or maybe the other two can comment that the DAPT durations at 1 year is about 70%. There's a significant number of people who actually had a shorter DAPT. Are you confident with the shorter DAPT with eAltiMaster, even though there is no specific short DAPT trials related to Altimaster? Jack?
So I think, I said, this real-world data was quite telling. Just based on this data alone, it looks very, very safe, in fact, of the shortened DAPT. The only caveats I'd like to caution is two. One is in the ACS, post-ACS indication or significant residual disease or complex stenting. I wouldn't necessarily say that a shortened DAP in those group is better. But I think the real results are quite impressive. And I think in the East Asia group, where they do a lot of intravascular imaging, I think they have shown that even a shortened duration of that seems to be safe potentially in the ACS subgroup. Thanks a lot, Huay-Cheem.
Fazila, I still cannot hear you very well. But Takashi, how often do you use a shortened DAPT for eAltiMaster or for Altimaster stent?
Now the Japanese guideline says stable PCI case recommended duration is 1 to 3 months, and STEMI or ACS case 3 to 12 months DAPT period. So I think the Altimaster is very safe for both ACS or stable PCI case. So I say roughly half of ultimate master case, I go straight to short term.
Very well. So I'm going to go on to the next speaker now. Dr. Jack Tan is going to present to us a case of primary PCI in cardiogenic shock. Jack, I'm going to let the take over the stage.
Good evening, everyone. My name is Jack from Singapore. Thanks for allowing me to join this session and do a case sharing on transradial intervention for AMI. These are my conflicts of interest and allow me to jump directly into the case. So the case I'm presenting today is a 58-year-old gentleman with prior history of known ischemic heart disease, evolved inferior myocardial infarction. We have PCI to the right coronary artery in 2011. 2013, he has a myocardial stress perfusion scan showing a large infarction defect involving the RCA territory, but was otherwise negative for ischemia, and therefore the remaining lesions was not intervened upon. He has risk factors of dyslipidemia, diabetes since 2003, and underlying psoriasis. So this gentleman then presented on the 16th November, just about 2-3 weeks ago. That's why I thought it was quite recent for presentation, for heart failure. His creatinine was normal. His NT-BNP was 4,578. His A1C level was at 10.3%, LDL of 2, and high sense TROP-T was high at 199. So this is presenting ECG with heart failure. He has bigeminy and some ST depression in the lateral leads. His admission chest X-ray had mild CCF clinically as well, and diuresis was done over 2 days. So 2 days after that, he had a 2D echo. It shows an ejection fraction of 15 to 20%, mildly dilated LV end diastolic dimension of 58, PA pressure of 40 with no scut segments. Usually this is my routine approach with ultrasound guided radial access. So I'll just spend a quick minute showing how it's done. The draping, everything is now very fast. So you identify the medial lateral landmark. The radial artery, you have to really zoom in because it's actually quite small. And after identifying the radial artery, positioning it in the middle of the probe, we give some local anesthetic, and it's very superficial. But what this technique allows you to do is to really have a front wall top puncture of the radial artery, and then you don't cause spasm if you do miss it. And this technique guarantees almost 100% success for suitable radial arteries. And with this method, usually the complication rate can be markedly reduced for radial approach. So we move on to a coronary angiogram. The patient has occluded distal RCA stent and the occluded RCA. And he has triple vessel disease, not surprisingly, with a tight circumflex artery as well as a tight bifurcation lesion in the LAD D1 and distal left anterior descending artery. So again, a tight circumflex as well as a tight lesion in the LAD. And this patient has triple vessel disease with EA of 15%, a diabetic patient. And we were counseling the patient about bypass surgery and is trying to convince him for bypass surgery. We haven't started anything. He went to refractory ventricular fibrillation. The radial shift was still then in. We had CPR for at least 30 minutes and multiple boluses of adrenaline, amiodarone, and we placed a mechanical CPR device, a Lucas, after he was intubated. So we called the ECMO team in, and then we initiated ECMO support. The Lucas device was removed with IBP and ECMO support. So the nice thing about this is that now we could approach a PCI without removing the IBP, as we have a radial access as well. So the PCI was then performed with a closed aortic valve on ECMO support. You can see that the patient actually have no ejection at all. So this is the final result. The procedure is done with ECMO and IBP support. The circumflex as well as LAD arteries were open. And we transferred him over back to the National Heart Center, and the winning echo study was performed roughly 2 weeks down the road, showing a recovery in the LV function. And we had an intra-op TE showing the EF improved to 25%. The patient was successfully explanted with stable hemodynamics. And you can see without the ECMO support, he had a stormy peri-procedural course. And just before he was explanted, his lungs fairly cleared out with some residual aspiration pneumonia. For bleeding reduction, this meta-analysis does show that radial versus femoral approach in primary PCI favors a radial approach in terms of bleeding reduction. And this is very much translated in this meta-analysis to a mortality reduction in terms of primary PCI with using a radial approach. In our APSC consensus statement, we also strongly endorse radial approach as the default strategy for anyone undergoing coronary catheterization or PCI. And nowadays, we have really devices, sheath that is tailored to hemostasis as well as access for the radial approach. Radial access have been made extremely easy with both radial board, radial sheaths, radial TR band, for example, for hemostasis access. So my conclusion is this: multi-vessel PCI during STEMI is warranted in select circumstances in spite of the coverage shock study, as in this case. But when patients are in such dire straits, cerebral protection with adequate mechanical CPR, ECMO support, and therapeutic hypothermia is paramount for good outcomes. And radial approach for STEMI is recommended to reduce bleeding complication. And I would strongly also advocate ultrasound-guided access to ensure a high success rate, as well as reduce complication for radial access. With that, I thank you very much and welcome further questions.
Jack, that must have been a emotionally enriching case that you have just done. I mean, the presentation was catastrophic, but the rescue measures were heroic and the outcomes were superb in terms of salvage. So I think there are a couple of questions that I'd like to ask you. Firstly is, do you believe that transradial does confer mortality benefit in patients undergoing primary PCI compared to a transfemoral? I mean, the meta-analysis, regardless, but if you look at the later trials, like Matrix, like Safari STEMI, none of these actually has shown a mortality benefit. And that's because transfemoral techniques have actually improved in terms of its bleeding avoidance strategies compared to a TRI. So what do you think?
So my own personal belief, Huay-Cheem, is that nowadays the intervention itself has been also made extremely easy, and with this sharing of techniques, it has been quite straightforward. Most of the mobility in a lot of our cases, whether elective or especially when you give a lot of anticoagulation in a STEMI setting, comes on excess complications and bleedings. So I think if you do refine your access technique, for me, a routine approach, whether it's femoral or radial, is ultrasound approach. And I think I picked the right spot to gain access. So I think you want to minimize this particular group of complication. If you do so, I don't think there is a fine or a difference in terms of mortality in this group. Again, the mortality in STEMI in previous discussion is related to cardiogenic shock, not directly due to bleeding in my read of the evidence.
Fazila, would you have sent these patients for emergency bypass surgery and having put in all the mechanical support?
That was such a great case. Congratulations for bringing the patient alive safely. So no, I think, realistically speaking, you wouldn't have got the time to arrange the logistics for arranging a surgery. It takes time. And that patient was literally dying in front of Jack. So great work, Jack. Congratulations again. I mean, that is the reality. Arranging surgery takes time. And especially in Bangladesh, it will take time. You have to arrange a lot of things.
Takashi, what would you do in Japan? I mean, you guys are pretty efficient.
Yeah, so this Jack's case is a very, very impressive case, and but ECMO and balloon pumping support, you gotta go to radial only, right? So you don't have any choice because both femoral are, ECMO and balloon pumping. So if in such cases, if you don't have a experience of radial artery approach, it's very difficult. But if you do a radial artery approach, as usual, it's easy to access a radial artery. So I recommend a radial access for all cases.
So
do you use ultrasound routinely to access your radial artery, Takashi?
No, exactly. I don't use ultrasound, but to prevent a breathing complication, yes, yeah. If you can use, maybe it's better to use ultrasound.
So why do you recommend ultrasound, Jack? I think most of us don't actually go for it unless there's something special.
So the reason, Huay-Cheem, is that I found that if you want to achieve a higher rate of access and means less failure, you really have to reduce multiple, what is called hairpin puncture or spasm. And the other main advantage is that you can really localize the anesthesia and do a front wall puncture. I found that a lot of times when you have hematoma in the arm, it's because the puncture you're moving from the side and you're doing a side wall puncture. And then when you compress it, sometimes it's not properly done, the hematoma tracks up. With a front wall puncture, it's actually much easier to control any radial access after the sheath comes out. And of course, I think you have to gain some experience. I started doing all routine femoral puncture using ultrasound to pick the spot, avoid the calcium, and do a front wall puncture. For radial artery, just note it's a bit smaller, so it's still a true Salinger technique most of the time, but you tend to get fantastic results. And of course, you also can assess whether there's a partial occlusion upstream or very poor flow. In this case, Takashi, if you don't have ultrasound and the moment they are on ECMO, on CPR, you can't feel anything to access a radial artery.
I think
yes,
that's right.
To consider ultrasound approach. And in most cases, when you don't have, when you inserted IBP first followed by ECMO, you have to railroad out the IBP to gain access for a PCI, and then you waste one IBP balloon after you reinsert. So I think this approach tends to save some equipment and have maximum support during PCI. Thanks, Huay-Cheem.
Thank you very much, Jack. I'd like now to invite Dr. Takashi to talk to us about handling TRI complications. Takashi?
Okay, today I'm going to talk about handling TRI complications and advancements in TRI. So transradial access is increasingly used worldwide for percutaneous interventional procedures. And in 2018 ESC guidelines, it was recommended as Class 1 radial access as a standard approach for coronary angiography and PCI. And Japanese guidelines for primary PCI, transradial access is recommended as Class 1 with level of evidence A. For operators experienced in radial artery approach should be performed rather than femoral artery approach. TRI is associated with lower bleeding and vascular complications than transfemoral intervention. However, there are still some complications we have to be careful. Common complications are hematoma or radial artery spasm, where complications are perforation by guide wire, shoot aneurysm, fistula formation, compartment syndrome, and so on. So to reduce these complications, appropriate hemostasis is important. So to reduce complications, you may use hemostasis devices. TR band is a unique device for selective compression of radial artery. TR band allows venous blood return and preserves vessel patency. So patent hemostasis using the TR band results in a significant reduction in radial artery occlusion. In previous slide, I didn't mention about this, But yes, actually, radial artery occlusion is most frequent complications of TRI. However, most of all the operators do not routinely check radial artery occlusion after procedures. As you can see, rates of radial artery occlusion is decreasing in these years. However, it is still about 4%. To reduce radial artery occlusion, cyst to radial artery diameter ratio is important. So we routinely use this glide cyst slender for patients with small radial artery or cases when 7 French guiding catheter is used. Because this glide cyst slender allows 1 French size reduction in outer diameter. So if you want to use a 6 French guiding catheter, outer diameter of glide cyst slender is equivalent to 5 French conventional cysts. Now I will show you one impressive case. This is a 60-year-old male with ACS. Culprit region was proximal AD, and this case was simple and successfully implanted drug-eluting stents, and the procedure was very simple case. However, after PCI, wrong hemostasis resulted in compartment syndrome. I had to ask a surgeon to treat this, and hyperbaric oxygen therapy and vacuum-assisted closure were performed. Unfortunately, this patient had residual stenosis of mid-RCA, so I treated this lesion using 5 French guiding because I didn't want to repeat the same mistake again. So case was simple and successfully treated. So this picture is very impressive. So right hand, 6 French guiding in 6 French conventional cysts and compartment syndrome. Left hand, 5 French guiding in 5 French glide cyst slender, which is equivalent to 4 French. So very small cyst, and you can see trace of TR band here. I use the TR band for hemostasis in this case. So TRI is final destination of PCI. Actually, TRI continues to evolve still now. These 2-3 years, a new approach has been introduced, which was distal transradial intervention. I will show one case. This is our left main bifurcation regions. Distal left main, proximal AD, proximal circumflex, and Reims intermediate. Very complex case. So what is your strategy here? Access sites transradial, distal transradial, transfemoral. How about guiding sites? 5, 6, 7 French, 1 stent, 2 stents. Do you have to protect frames? Very complex case. So maybe some people think bypass for this case. Actually, my strategy was this. Distal transradial, 6 French, 2 stents, need to protect frames and treat already aneurysmal parts. To complete my procedure, glide cyst slender is the key. Again, 6 French guiding, you can use 5 Frenches. And also, distal radial artery is roughly 0.5 millimeters smaller than radial artery. So for distal transradial approach, you have to use a smaller cyst. This is a puncture of distal artery, and I use 6 French glide cyst slender, which is equivalent to 5 French conventional cysts. So for this left main true bifurcation region, I did DK cross stenting using RT-master Tansei. RT-master Tansei stent design is suitable for bifurcation region. Open cell two-link design is its side branch access. Longer cell length, bigger cell diameter than other DS, and uniform scaffolding enables optimal coverage of bifurcation anatomy. This is our final IVUS of left main, LAD ostium, and circumflex ostium. And this picture shows how to do hemostasis in my cath lab. Just 3 hours compression by bandage, successful hematosis was done. So thanks to Gratis render, this complex PCI case was completed with this tiny hole only. It's kind of evolved TRI. So TRI is increasingly used worldwide and associated with lower bleeding and vascular complications than TFI. To manage complications, appropriate hemostasis and selection of Cs is important. Distal transradial intervention is a new option of PCI. Thank you for your attention.
Thank you very much, Dr. Takashi Kajiya. So you have just done a complex two-stage procedure using a 5 French guiding catheter. So through a 6 French slender sheath, as I understand. So you like to make things a little bit more challenging for yourself. I get it. I was just reading a meta-analysis comparing distal transradial versus a conventional transradial in the CRM journal just published only in October. And distal transradial intervention in that meta-analysis has not been shown to lower the incidence of hematoma compared to transradial. It has not been shown to reduce spasm compared to conventional. And it also has not been shown to reduce dissection of the radial artery. The only advantage that has been shown in that meta-analysis was a reduction in the radial artery occlusion from a distal TRI approach. So I just want to ask you, what sort of patients would you choose a distal transradial intervention approach compared to a conventional TRI, given that there is no proven benefit in terms of hematoma, bleeding, but certainly adds another level of difficulty in terms of doing the procedure. So who are the patients that you will choose for a distal TRI?
Thank you. So still, it's just the optional approach. I think I don't say the distal transradial is the first choice, but if we hope the preserving a radial artery is better for patients. I mean, if distal transradial was occluded, still the proximal radial is patent. So sometimes we need to repeat a PCI or angiography, and in that case, some the radial arterial occlusion may occur in the future. So the distal transradial is is an approach, is an option to preserve a proximal radial approach. So we need to data, yeah.
Okay. So I have one more question before time runs out. Compartment syndrome is a catastrophic complications of transradial intervention. So what is your algorithm in terms of treatment of a patient whom you suspect to have a forearm hematoma, possibly progressing to compartment syndrome? What do you do in your lab?
Okay, so the most important thing is to find a hematoma as soon as possible. So if you find a hematoma, the early period, you don't worry about too much. So just compression, just proximal part compression is okay. But if you find a hematoma, very late, we have to do a escalotomy, so the very catastrophic case. So I think the most important thing is appropriate hemostasis and to find a hematoma as soon as possible.
So I think so what we do here is in my center is repeated cuff compressions against above the systolic blood pressure, just to make sure we stop the bleeding. Do you reverse anticoagulant in your practice?
No,
when you
no,
have a
we
patient
don't.
No reversal of
don't do.
anticoagulation. Okay.
No.
So I think we come to the end of this very nice symposium where I learned a lot from all my three speakers. And I think we have learned about e-Ultimaster, showing that this stance is certainly living up to our expectations as with all newer generations DES, with its high efficacy as well as low stent thrombosis rate and excellent safety profile. We also learned from Jack that TRI is possible even in the patients who is very, very sick, and then you could actually salvage them even while your heart basically going into asystole in a multi-vessel cardiogenic shock setting. And Takashi Kajiya taught us about the technique of transradial intervention complications management, particularly with regard to compartment syndrome and also advancement in terms of a distal TRI approach. So with that, I'd like to thank you, all the speakers, as well as the audience for staying up all the way to the end of this AICT-AsiaPCR symposium. And that I'd like to pass on to Dr. Rosley and the rest of my co-directors to close the meeting. Thank you.